don't know if we can admit all.
There's someone still waiting in the lobby, isn't there?
There's lots of people. I would just assume there would be an admit all.
Yes.
I think most people are in now. We're just waiting. There's a couple of people who seem to be stuck in the lobby, including one of our speakers. I can't see how to admit.
Okay. So I need to check this out.
I should
Welcome,
have just
everyone.
admitted Kurt.
Apologies for we're just trying to make sure everyone's admitted. I think they are now, which is fantastic.
Is Kirsty Robertson here?
I think she's just been admitted in.
Yeah.
Excellent. Okay, sorry, we could see you were stuck in the lobby and we couldn't work out how to get you in.
Thank you.
Right, welcome everyone. Thank you for joining us for our CBD call to action on lipids. My name's Helen Williams. I'm a consultant pharmacist at South East London ICB, specialising in cardiovascular disease, and I'm really pleased to welcome everyone to the session today, as we have a great lineup of speakers who are going to take you through some of the tools, some of the challenges, some of the potential solutions as to how we can improve our patients' lipid management. So I'm going to introduce people as we go along. We've just had the agenda up, but I am going to try and share my slides, because what I want to do, my job today, is to set the scene with a few slides just showing where we are in South East London. I can get them to full screen. Can I just check they are full screen for you, or are they presenter view?
They are full screen, Helen.
Fantastic. So, lipids are call to action. A bit of context, really. Where are we with CVD prevention in England today? Well, for the first time in decades, we are seeing increased cardiovascular disease mortality. We saw great reductions up to around 2012, after which our cardiovascular disease mortality plateaued. And since around 2019, we have seen increase in cardiovascular disease mortality for both males and females. And it's really important to understand there are also health inequalities underpinning that, because cardiovascular disease mortality is twice as high in the most deprived areas than the least deprived areas. For example, why do I think cholesterol is important in this context? Well, if we look at the death rate from cardiovascular disease risk factors in the UK, we can see that there are a number of things that are in the gift of the NHS to address. The leading risk factor causing death is the high systolic blood pressure, and there's been a lot of focus on that for many years. But second to high blood pressure is high LDL cholesterol. So really important that we do think about cholesterol. Many of our patients with high blood pressure will also have cholesterol that needs to be addressed, whether they are patients who have cardiovascular disease or those who are at risk of cardiovascular disease. So it's something we can't ignore. If you want to turn that tide of increasing cardiovascular mortality, we've got to take a really comprehensive approach to risk factor management. Systolic blood pressure, obviously really important. Definitely LDL cholesterol, also thinking about CKD, overweight and obesity, smoking and diabetes. But LDL is right up there as one of the most important risk factors. If we look at national data, we can see that for prime prevention, if we look at 20% Q risk or more, that's the grey line, national at 63.6%. If we look at the blue line, which is Q risk or more than 10%, we are at 55.6%. So there's more than 3.1 million people on GP registers across England with a Q risk score of 10% or more, or who are not currently on lipid lowering therapy. Using the CVD Prevent data, we can drill that down for South East London. So this is looking at Q risk score of 10% or more. Patients who are currently treated with any lipid lowering therapy, not just statins. The blue line is the England average. The black line is South East London, and you can see we are a few percentage points below the average. at around 52%. It is going up, but as I say, we are behind the rest of the country. And if we calculate the absolute numbers of patients in South East London, more than 80,000 people on GP registers in South East London are recorded with a Curie score of 10% or more, and they're not on any lipid lowering therapy. So if they can't take a statin or won't take a statin, should we be offering alternatives in line with NICE guidance? And that would be ezetimibe and bempedoic acid. If you look at secondary prevention at a national level, so the first of our QOF indicators is to get people with CVD on lipid lowering therapy. And nationally, we've got around 85.5% of patients on any form of lipid lowering therapy with CVD. So it still means about 14.5% of patients with CVD are not receiving any lipid lowering therapy, and that amounts to 400,000 people across England. If we look at treatment to target, so getting people on lipid lowering therapy isn't enough these days. We know that we need to achieve the lipid targets outlined by NICE. In the last year, over 500,000 people with CVD didn't have a lipid check in the last 12 months, so they automatically failed NICE. And you might expect that in South East London we suffered in this indicator because of the Synovis cyber attack, where we couldn't necessarily check blood. So I think we have some reason for not being able to do our tests locally, but still over 500,000 people in England didn't have a lipid check in the last 12 months and automatically failed QOF for the treatment to target indicator. And a further 940,000 or so did have a check and aren't treated to target. So nationally, we're below 50% of patients treated to the NICE targets of an LDL less than 2 and a non-HDL less than or equal to 2.6. As I say, we can drill that down again. For South East London, this is looking at people with CVD who are on any form of lipid lowering therapy, and we're very close to the England average, which is encouraging for this indicator. Still a couple of percentage points behind. And if we look at the absolute numbers of patients, more than 9,000 people with CVD in South East London not receiving any lipid lowering therapy. And if we look at treatment to target, this is where we are a long way behind the rest of the pack. And we can't particularly blame Synovis for all of this, because even in June, before the Synovis issue, we were well below the national average, and it fell in September, and we're still obviously in a recovery phase now to try to catch up. So we are improving. There has been improvement between September and March 25, but still less than 40% of our patients are currently achieving the NICE treatment targets of an LDL less than 2. Remembering, of course, that in Europe, the target is less than 1.4 LDL. So we've not got the most aggressive targets in the world, and hopefully we can improve on this. If we look at the absolute numbers, 36,000 people with CVD in South East London not currently achieving NICE treatment targets. So they are probably my highest priority cohort, because if we can get these patients to target, we should be able to deliver much improved outcomes. This is where we sit compared to other ICBs in the country. So every blue line there blue bar represents an ICB. We are the second poorest performer on the treatment to target indicator. Absolutely accept that Synovis contributed to that, but clearly we do therefore have to put a bit more extra effort in. And one of the things I would say for treatment to target is, because you have to do the levels, find out they're not at target, initiate a therapy or optimize the treatment, and then wait 2 or 3 months. We can't afford to do this in January. We need to be starting to do this work now to be able to deliver targets by March next year. Just wanted to also highlight health inequalities in lipid management. This looks at deprivation in South East London, and the most deprived areas are the least likely to have patients with CVD treated to the lipid targets. The most deprived areas, and the least deprived areas are much more likely to be at target. So more deprived, lower achievement of targets, less deprived, greater achievement of targets, and then the spread of the quintiles in between. If we look at ethnicity, Our Asian patients nationally do very well, and also in Southeast London. Our Black, African and Caribbean and mixed race patients do the poorest in terms of achievement to target. Our white patients sit about halfway between those two cohorts. And if we look at gender, so sex, males are much more likely to be treated to target with CVD than females. So despite having diagnosed CVD, women are less likely to be given lipid-lowering therapy and less likely to achieve target. There's almost a 10% difference between men and women in this indicator. And that has been noted nationally, but it's something we need to be aware of going forward. So we can calculate the size of the prize for East London in terms, this is just looking at patients with CVD being prescribed any lipid-lowering therapy. In the vast majority, you would expect it to be statins. If they can't or won't take a statin, think about ezetimibe, think about inclisiran. If they are intolerant to statins, then the possibility of bempedoic acid comes into play. If we could get to 90% of patients treated with lipid-lowering therapy with CVD, it means treating another 3,000 patients in Southeast London, and we'd prevent almost 200 cardiovascular events over the next 3 years. If we can push that to 95%, then we would treat just over 6,000 patients and prevent 374 cardiovascular events. This is just initiating your first lipid-lowering therapy for patients with CVD. I believe we can get over 90% because we've done it in AF with anticoag, which is a high-risk drug in an older cohort of patients. So there's no reason why we shouldn't be able to get over 90% of our patients with CVD on some form of lipid-lowering therapy. There has been a big national push around addressing some of the inconsistencies in how we manage cholesterol. So new NICE guidance with clear targets, alignment of the QOF indicators, and a lot of extra funding has gone on this year for both hypertension and lipid indicators. We've got updated national lipid pathways, supporting simplified HIN pathways for secondary prevention. And locally in Southeast London, I'm sure one of the other presenters will highlight that we have simple local guidelines for both primary and secondary prevention. Lipid management is embedded as part of the National Medicines Optimisation Opportunities Plan. It's integrated now into the Community Pharmacy Independent Prescribing Pathfinder programme nationally. And we have 3 pharmacies in that programme in Southwark who are currently able to initiate and manage people with high blood pressure, but also initiate lipid-lowering therapies if appropriate. So 3 sort of key messages about what we really want is this pathway approach to lipid management. We should be empowering our patients through shared decision making. We should be initiating and optimizing high-intensity statins, supporting medicines adherence and addressing any adverse effects that people might have early on, and then intensifying therapy so that we can treat to target. And we should be using the full range of lipid-lowering therapies, both oral and injectables, in line with the NICE eligibility criteria. So I am going to finish there. I will stop sharing my screen and I will be handing over to Kessel. Let me just stop sharing. Lara Elwash is going to talk to us about Kessel, and hopefully I can find you all again, the lipids quality improvement offer that Kessel have in place. So thank you for joining us, Lara.
Thank you, Helen. Can everyone see my screen and hear me okay?
Yes, we can hear you and see the screen.
Brilliant. Thank you so much. Good afternoon, everybody. I'll just start with a bit of introduction. I am Lara Elwash, clinical lead in Greenwich for the Clinical Effectiveness South East London. You might know it as Kessel team. And I am here today to talk to you about lipid management and how we can support you and your team in improving outcomes for those who might fall within this cohort of patients. Just before we start, I'd just like to acknowledge the great collaborative work that has been happening in the background between both the Kessel and the Medicines Optimization team to bring about this presentation, which will highlight why lipid management is such an important priority for us now and share some of the latest guidelines and local examples, and most importantly, give you some of the practical tips that you can take back to your own teams with the support we are offering from Kessel to help you make the right thing to do, the easy thing to do. So my first slide on there is why we're focusing on lipid management, and I wanted to go the stats with you, but Helen has covered it really nicely in her presentation. So I won't do a repeater on that, but I just wanted to remind everyone that this is backed up on a national level. And as you have seen this QOF year in 25-26, nearly a quarter of those QOF points are dedicated to cardiovascular disease prevention with a focus on cholesterol and lipid lowering therapy. So clinically and strategically, this really matters to all of us and reinforces the importance of the work for practices like yours. But the key question here is, how do we do it? And that's what this presentation is designed to help you with. I've got on here examples of where practices have already integrated lipid management into everyday care, and that has been really recognized and helped them with their workload significantly. And this was done by running lipid clinics alongside other long-term conditions like hypertension, diabetes clinics. So appointments were very well utilized and were very effective for the patients. Again, this is just an example of how some practices have done it. This can be tailored to your needs because not all practices are the same. So the examples we've come across during our visits from Kessel is that practices have had 3 sessions a week to do those clinics, 1.5 hours each with a 15-minute appointment. And the key in that they've had a lipid lead in-house, that either a clinician or non-clinician, to have a full oversight on the whole process. It's like a project manager, let's say. Blood test results would be requested by them and triaged by that lead, and the results would be dealt with based on the calculated Q-risk score by the appropriate team member. I've only touched briefly on this here because I know my colleague Kirsty will showcase the great work her PCN has done on lipid management and how they've responded really well to the challenge. So more on that later. Practices have also shared with us some practical tips from first-hand experience that are worth highlighting. And from the list they've shared, actually there are 2 themes on there that I've really picked up on. And the first one is supporting patient decisions. So starting by tackling statin hesitancy, intolerance. Why is the patient declining, reluctant to take statin? Maybe they've been taking it but have stopped now. Are they experiencing any side effects? So essentially understanding the root cause of what's happening. What is the patient past experience? That is very vital. And having this conversation at an early stage, like Henel mentioned, it does take time to adjust treatment and harvest those results at the end of the QOF year. But practice did highlight that they found using the Southeast London statin intolerance pathway can really help them during those conversations because it gives the guidance on what needs to be done next. Also, tools like GP evidence, it allows you to put things in perspective for the patient, tell them what the actual risk involved here, and also linked to that is the NICE patient decision aid to tell your patients why should you take a statin, and the critical bit in there is to give those resources during that thinking period where you've had the consultation with the patient understandably wants to think about this. So providing these resources during that thinking period via Accurex message or a handout is really vital and will support that shared decision-making process with them. And the second theme I've picked up on there is optimizing practice processes. So making use of the Arden's resources, like the pink alert box on the right-hand side of the EMIS screen. It gives you lipid prompts, search tools for identifying patients, and templates to make sure you've covered everything in the reviews that needs to be covered and the coding is accurate. And these will help you prioritize follow-up blood tests after dose changes or when adding, for example, ezetimibe to capture those improvements and monitor progress effectively. My colleague Matthew will take through take you through an example later on of how to best utilize Arden's manager. So I'll leave that bit to him. I won't go into detail, but the key messages across the tips that was shared, I would say, is to think lipids at all times. Make sure lipid management is embedded in those relevant long-term condition reviews, structure medication reviews, rather than standalone item or standalone condition that you are trying to manage. And we've done this really well in Kessel, where we've incorporated elements of this in our CKD guide, diabetes guide, to help you think about it this way. So yes, you're looking at diabetic patients, but are you looking at the lipid profile? How can you bring lipid management into this? So hopefully that would be helpful for practices. And the next 3 slides I've got here are just basically a summary, I would say, of the QOF indicators for this year. So there are, as you can tell, there are clear expectations around cholesterol management for 25-26, but sometimes the wording on those indicators can be a bit complicated and a bit confusing for some. So I want to kind of debunk those and exactly let you know what is the ask here basically from us, from general practice. So starting with the first two, so the COL 003 and the COL 004, these are based on secondary prevention. So looking at patients with cardiovascular, established cardiovascular disease and chronic kidney disease, they should be prescribed a statin or another lipid lowering therapy. And once those patients are on a statin, or if they are historically been on a statin, we would start looking at treatment to target. So that would be your LDL of 2 millimole per liter or non-HDL of 2.6 millimole per liter or less. And these are achievable if we have a process in-house that is solid, that will allow us for consistent follow-up. The next 2 indicators are related to diabetes. There's quite a bit of weighing on those, and they are split into 2. The first one is primary prevention, and the second one is secondary prevention. Starting with the primary prevention, those are diabetic patients aged 40 years and over without cardiovascular disease or severe moderate frailty, and they have a Q risk of 10 and more. So they are at risk of cardiovascular disease. So those patients would be should be offered a statin or another lipid lowering treatment. And for the 4th indicator, that is your based on secondary prevention. So those are your diabetic patients who already have an established cardiovascular disease. Again, same expectation is to initiate a statin and optimize as necessary, or using another lipid lowering therapy. So to be honest, frankly, just reflecting on this, if we do follow the guidance by NICE and especially the SEL IMOC guidance on this for lipid management, we will naturally achieve those targets because it's part of our day-to-day clinics, and that might be easy. That might be easier said than done, but it does work out if that's actually embedded and we are following the guidance we should be. And we've seen that in practices across Southeast London. And the last QOF indicator is based around mental health. So for patients with a severe mental illness, practices should ensure there is a lipid profile on record. And that means every 12 months. If a patient is on an antipsychotic, has cardiovascular disease history, smokes, or overweight, then a lipid profile would need to be checked. For all others, the time frame would be at 24 months rather than 12. But it's really important with this indicator to understand the aim of it, and it is set up to help address the reduced life expectancy of around 15 to 20 years in patients with severe mental health illness. They're often at a much higher risk of preventable physical illness, but less likely to receive consistent physical health monitoring. So unfortunately, sometimes they do slip through the net. An Arden's manager will support you in picking those patients up and address this major health inequality experienced by this cohort of patients. So what does all this mean to us in practice? And there are a few things to consider here. Starting off with, the full utilization and usage of the updated SEL IMOC guide and the webinars that we have been having over the summer. They are recorded on and are on the South East London website to go back to. They have a lot of resources in there, and probably the questions you might have on mind, they probably are answered in those webinars. So really important to check those out. The second one is to have, we've mentioned before, having a robust process for identifying, recalling, and reviewing patients early, because it does take time to reach target. Third is empower your patients. Share the resources with them during that thinking time to kind of consolidate the information you have discussed with them, and also to give them the ownership to look after their own health. And fourth is to make sure you use the whole workforce, because this cannot be done by one person. It will be really challenging. So you've got pharmacy technicians, healthcare assistants, admin staff, care coordinators, and the wider team. They all can play a role, and we will see that later on in the webinar. And finally, treat lipids as the bigger, as part of the bigger picture. Manage them alongside other risk factors, just like how we have shown you during our KESEL visits with the Vital 5 guide, and how to manage those those challenging conversations. There are consultation prompts in there that you can adapt and facilitate those conversations with the patients and support in tackling statin hesitancy and intolerance. And that's where is our offer to you. The KESEL team is here, as always, to support you and your practices. We can help you directly, whether at practice level or PCN level, to improve lipid management and share the learning across SEL from workplaces where they've done this really well, and learn from each other. So if you'd like support from us, please do get in touch. You've got our email address on the screen. And yes, looking forward to hearing from all of you. And that's all from me. Thank you so much for your time. And if you have any comments or questions, please pop them in the chat and I'll happily pick them up. Thanks.
Thanks so much, Lara. Really interesting. Lots of pointers for people as to how they might manage their lipid patients more effectively. I'm going to whiz us straight on. We do have space at the end for Q&A, but we are running a little bit behind time. So I'm going to introduce Tony Wisbecki from Guy's and St Thomas's Trust, our resident expert in lipid management, and he is going to talk a bit about lipid management from a secondary care perspective.
Okay. See, so I just want to check, are the
slides are up, but they're not full screen yet.
Yeah, that's fine. Oh. Okay.
Thanks, Tony.
Right. Thanks, Helen. I'm Tony Wisbecki. I'm head of the lipids at Guy's and Thomas's, and I have sort of various other regional and national roles. So I'm just going to give you a quick introduction to lipid optimization and injectable therapies and where we stand. We, as Helen has said, there is a full and short, it's actually about 10 pages of guideline to how you should actually manage lipids. And this is sort of agreed nationally, so there's nothing unusual in this. And I'm going to concentrate on second intervention because they're the highest risk, and that's where the QOF target is. So the aim is that we're aiming for an LDL ideally under 2 and a non-HDL under about 2.5. Statin intolerance, I'll go through in a little bit more detail, but statin intolerance is one of these things that has been hugely hyped, and the reports on social media are tenfold excess over reality. So the real rate of statin myopathy is about 1 in 50, and generally it'll occur within the first month of starting the drugs. So we've been doing extensive work, as already been stated, in lipid transformation. So we've got predict and prevent projects, we have community hub pilots, and we have CVD risk reduction pharmacists that have been funded by the ICB and are now gradually being put into Trust and ICB business plans to support practices with a little bit more expertise before requiring secondary care clinicians. So where do we start? Well, basically any LDL reduction will help reduce cardiovascular risk, and there is a very simple rule that every 1 millimole that reduces LDL cholesterol reduces cardiovascular events by about 20% over 5 years. And it applies to all lipid-lowering therapies. So it doesn't matter how you do it, getting it down works. Secondly, there's a large amount of debate about targets, and you'll sometimes hear cardiologists saying we should go to 1.4 or 0.8. In actual fact, the lipids, the benefit from lowering lipids extremely gets less as you got lower down. And this is an American slide, an LDL-C of 100 is 2.5. So you can go to see going from 100 to 75, which is from 100 to just under 2. You get a small extra benefit. And that's why NICE has been more conservative than European and American guidelines and said less than 2. There's also been a recent trial in people with coronary vein bypass grafts showing that lowering LDL more doesn't save those vein grafts. It's caused by something else. So under 2, definitely. Less than that, probably don't worry about it too much. And remember, lipids vary by about 20 to 30% anyway for LDL-C, just due to daily variation. So you'll get them there if you get them around 2. The other thing that we've been dealing with a lot is statin discontinuation. The rates are about 25% in second intervention after about 3 to 5 years, depending on the country, and about 40% in primary prevention after about the same timescales. And this has consequences. So this is from Danish data showing that if you stop your statin immediately afterwards, you basically go back to the line if you haven't been treated at all. And that gives you excess cardiovascular events. That's why we're making such an effort to try and find people who on cardiovascular disease registers that should be on a statin or lipid lowering and aren't, and get them back on it. It really will make a difference in terms of their events in the future. So I've mentioned statins and myopathy and muscle pains. Most muscle pain, as I said, doesn't affect CK at all. The vast majority of that we see it is on the left-hand side. It's these kind of factors. A lot of this is excessive physical activity. CK rises can also occur after if you're doing endurance sports or do a session down the gym. If you've got cramps or muscle pain for other reasons, you are more likely to get them. It may not be the statin. For other things, well, we do have some drug interactions. Most of these aren't relevant because we don't use very much of them. Amiodarone, verapamil to some extent. We also do have some antibiotics that actually interfere through CYP3A4 and can raise statin levels. So just keep an eye out for interactions, as that may have precipitated why someone stops. If someone has severe muscle pains, give them about 2 months. That's the length of time this usually takes to recover and restart them. If they've had a rhabdomyolysis, which is a CK muscle pain and a CK of over 10,000, that's very rare. Generally, it's multifactorial, but in that case, you can't give a statin for 2 years. Which statin should we give to people who are intolerant, say that they're intolerant to the first one we give? Well, one of the newer ones. Quite commonly what you see happening in primary care is they try atorvastatin or rosuvastatin, patient doesn't tolerate that, and then they go to pravastatin or occasionally simvastatin. As you can see, this is the long-standing data comparing how tolerable these drugs were in their licensing trials. And you can see that the modern agents, atorvastatin and rosuvastatin, were far more tolerable than the older ones, even though they're stronger and even though the doses might appear higher. So use newer agents, they are actually better tolerated. There are various schemes for managing statin intolerance. Just look at the ones that survived through the SEL group. You'll see that this is sort of the ones from America and from the European Heart Journal. And basically, they're just effectively saying, give a break and re-challenge with a different agent or switch to a non-statin lipid lowering, depending on the forms. So which is our main non-statin lipid lowering? It's a drug called ezetimibe. It's gut acting. It's basically a turbocharged form of plant sterols, Benecol, Fluoroproactor, whatever you want. It's just 5 times as effective. It gives you an average of 0.5 on LDL added to whatever you've achieved on the first line drug like a statin. And it works. It reduces CVD events in all groups, and it's pretty well tolerated. Most recently, we've had a direct trial that has directly looked at giving a high dose statin, such as atorvastatin 80, and comparing it with giving a moderate dose statin, such as atorvastatin 20, and adding ezetimibe. And that was the racing trial. You can see it was powered for equivalence, and there's actually very little difference in terms of outcomes. But if you look on the right-hand side, you'll see you've got a little bit more LDL-C reduction with the combination, and you got half the side effects. So if someone's getting mild side effects on atorvastatin 80 intervention, just drop them down to 20 and add ezetimibe. You're going to end up at about the same place. If you need a little bit more, drop them down to 40 and add ezetimibe. It is actually will give you better results and is more tolerable. The other thing we can do for people who are statin intolerant is that we can alter the timing of the statins. This is work that we did many years ago, and many lipid units use it around the country. If you can't take a statin daily, you can use atorvastatin alternate days. It will still work. You can use rosuvastatin once every week, and it will still work. And this is 5 milligrams of rosuvastatin, showing that even there you get 25% LDL reduction, even given once weekly. And you'll see lipid clinics typically combining once a week rosuvastatin with ezetimibe on other days to get your 40 or 50% LDL reduction. And basically we managed to get 95% of people who couldn't tolerate any statin. Virtually every of these patients had 3 daily statins and couldn't tolerate them, back onto something with a mixture of rosuvastatin and adding in ezetimibe as necessary. The other option that we have is if patients are adamant that they won't take a statin or once weekly rosuva doesn't work, is that we have a liver-specific drug called bempedoic acid. It acts only on the liver, and it reduces LDL cholesterol by about 25 to 30%. There has been an endpoints trial in people who are statin intolerant, and it delivered a reduction in CVD events, so it does actually work on outcomes. The downside of it is that the response to it basically divides into 2 categories. On the one hand, you have patients who say that they get all the side effects they've had with the drugs they tried previously, and that you really need to go into the psychology of their statin hesitancy or drug hesitancy, because they will react to whatever you give them. The other side mimics more what we saw in the clinical trials, which is that people take it, they rarely have side effects, and what they do have is gout, known side effect to this drug, so make sure if they've got a high urate or an anti-gout agents, they're well controlled, or if not, it can slightly blip liver function tests, but then so can virtually all lipid-lowering therapies. So that's bempedoic acid, and you can add that to ezetimibe or a statin as needs be. Lastly, we have injectable therapies. There are 2 groups. There's the antibodies, evolocumab and alirocumab, mostly used by lipid clinics because they're a hospital-prescribed medication, mostly used in people with monogenic familial hypercholesterolemia. On the other hand, we have inclisiran, which is a slightly different technology. It's a small interfering RNA, and due to the vagaries of drug price reimbursement and deals done in the NHS, it is actually more cost-effective to use inclisiran, so that has been recommended for second intervention with an LDL-C of over 2.6. It's given as subcutaneous injections every 6 months after a 3-month loading dose. Theoretically, it can be given in primary care, and in many kind of places around the country, it is given by primary care because it's green lighted. However, in London and in other areas, there has been distinct reluctance to do it, and we have had to take on giving it in secondary care through the lipid clinics. That is a fast exhausting resource because we are almost up to limits. And I can tell you that of the 5 major sectors in London, 4 of them are at limit for capacity for how many people they can put on inclisiran. So if
Tony?
you're happy to take on inclisiran and the practice is happy to take on inclisiran after the hospital's initiated it, please do so. You'll be helping us out enormously. You even get paid a little bit more now than you used to. What do these drugs do?
Tony, I'm really sorry. We're so behind on time. Could you have 15 seconds to wrap up?
Yeah.
I'm
so
really
these
sorry.
drugs work. They reduce cardiovascular events. They reduce that. Target people appropriately as per the risk, and these are my conclusions. So explore reasons, check comorbidities, intermittent dosing, switch agents, and PCSK9s for those insane intervention that don't reach target despite anything else.
Thank you, Tony. That's really helpful. Really good to get an overview of the options we have for intervention. We are running a bit behind time, so we might not have time for we did propose to have about 10 minutes for Q&A at the end. If we don't have time for a Q&A, we'd really like you to put your questions in the chat box, because we can collate them and answer them and get them out to you after the fact. So if you do have questions for any of the speakers, please pop them in the chat, and we will move on to the next speaker, where we have a great example of best practice from Blackheath and Charlton PCN. Dr. Kirsty Robinson, I think, is here to talk about their approach to lipid management in Blackheath and Charlton.
Hiya.
Hi.
Bear with me.
Hello there. I am helping to share the slides, but I'm not being able to do that. Would you mind please grant me the access to share?
I will have a go. Otherwise, hopefully, make a presenter. There you go. I think that should work.
Perfect. Thank you.
Thanks, Kirsty.
Thank you, lovely. So as Helen said, my name is Kirsty. I'm actually a pharmacy technician working for Blackheath and Charlton PCN. So I've been asked today just to sort of showcase what we're doing in terms of lipid management via a PCN approach. So this is just a bit of a background. So across our PCN, we have a repeat prescription protocol. So this is adapted slightly to each practice, depending on the needs. But in this policy, it is stated that medication reviews are required annually. There are exceptions, obviously 6 monthly for controlled drugs or dependency forming medicines. And in each of these annual reviews, a lipid profile is requested as part of the blood monitoring. So we do a lipid profile for a lot of our patients, anyone that's complex, polypharmacy, or anyone aged over 40. So the pharmacy technicians at the practice have an oversight on these medication review, the workload. So we run searches as to how many patients we have every month, and we will send out the messages to book these patients in. So when the results come back from the blood tests, we have something in place across the whole of Blackheath and Charlton practices. It's a digital tool called GP Automate. It is self-funded by the PCN, but what this does is it screens the blood results for lipids, and anyone with elevated results or anyone with a Q risk of over 10, these results are sent directly to the pharmacy team to action. So that's a bit of a background, but the in terms of the processes we have in place for primary prevention, the pharmacy technicians, we run a quarterly EMIS search. So this is a self-built search in the practice, and this search identifies all the patients that are not on any lipid lowering medication that have a Q risk of over 10 and no decline codes on their record. We have a questionnaire, a Florey questionnaire. This was, again, self-built. It was created by the pharmacy team and approved by the practice clinical lead, which we send out to these patients. And this questionnaire just tells them that their last results were elevated. They would be eligible to start a lipid-lowering therapy. And we ask them if they'd like some more information or would like to start, to reply with yes. And we can get those booked in, or they reply no, and they can be coded accordingly. This is both done by the pharmacy technician, so they are triaged. If they come back yes, they will be booked in with a pharmacist, or if the technicians are trained, they can be booked in with the technician. If they are non-responders, the technician will call the patient, and again, they'll ask them the same over the phone. If the patient is keen and the pharmacy technician is trained, the appointment will be done then and there. If not, then they'll get booked in with a pharmacist. And we also do this for all lipid-related tasks generated by our GP Automate. So these will get into our task inbox, and then the pharmacy technicians will triage as the following. So as you can see from the table, if they're out of range but Q risk is under 10, regardless of whether they're on a statin or not, they're booked in with the technicians for lifestyle advice. If they're out of range, Q risk is 10 or over, and they're not on a statin, they're booked in with a pharmacist, or if your pharmacy technician is trained, they can be booked in with your tech. If they're out of range, over 10 Q risk, and they are on a statin but not on maximal dose, again, this can be the pharmacist or the tech if trained. And lastly, if they're out of range, over 10, and they are on the maximum dose, then these will just be booked with a pharmacist to discuss the next step, whether that's adding in ezetimibe or referrals to the lipid clinic. And so additional to that is obviously the secondary prevention, which is key because this is QOF. And as Lara has gone through, these are our main indicators that the pharmacy team, our PCN pharmacy team, lead on. So the COL 003, so this percentage of patients is, this search is downloaded by the technician, and each patient will be gone through. If they have been newly coded with one of these problems this year, then they will need a new questionnaire. So we have a lot of different questionnaires which have been self-created by the practice. So this questionnaire will be slightly different from the one before, because it will say due to your medical condition, it is recommended that you would start a lipid lowering therapy. And again, they're given the option to book in with a pharmacist or decline, and the technician will triage those. If they have already got a decline code from the previous year, they get a different text. So this will say, you've had a conversation with us last year and you declined. You know, would you want to have a conversation with us again this year or decline? So we give them the option. All non-responders get a telephone call from a technician, exactly the same before, whereas we can ask the same questions and book in as relevant. We have designated QOF slots in our practice, so all those appointments can be booked in with those in those slots. So if a patient does call back, a receptionist knows they can book straight into those QOF slots. In terms of the CHOL 004, so this is mainly to do with being in range. So with that, the tech will download this same search, go through all the patient lists. Anyone that's not had a blood will request a blood test if they haven't had bloods in the last 12 months. If they have had bloods at least 3 months ago, and they have had a change to their statin, and the technician will then request another blood test in hope that it's now in range. If they're out of range but they haven't had any appointments, then they get booked into one of the QOF slots. And the last one we look at is the DM035, the diabetes indicator. So we have a designated diabetes nursing team across each practice has this. They lead on this section, and they will book in appointments in our pharmacy QOF slots if the patient requires a statin initiation. So these are just some of the searches that we use in the practices. These are all the Arden searches for CVD primary prevention and secondary prevention. In terms of the primary prevention, this is patients with no CVD history and no lipid lowering therapy. And the secondary is patients with a CVD history and no lipid lowering therapy. They're worth having a look at and using because they're very beneficial. So this is some data we've got in terms of our practice. So we're where the green dot is. So we're Blackheath and Charlton. So we are sitting above the South East London average. So South East London average is 37.55, and we are sitting at 38.77%. So we've got a bit of work to do, but we are above the average. and this one is for CVD cholesterol monitoring. So again, the South East London average is 73.67%, and we're sitting at 79.5, which is quite close to the England average of 81.37. And seeing as we're sort of halfway through the QOF year, we still have time to get up there. So I've just been asked about a few obstacles that we face and some solutions. So in terms of obstacles, there is a lack of training for PCN staff, especially technicians. They are underutilised. So it is ideal to try and get some training in place for your technicians. The priorities and the protocol variations, these do vary GP to GP. And if you're working across multiple GPs, these can change. Ongoing overwhelming workload, that's for everyone, and it's both clinical and non-clinical. It is quite a big workload, the lipid management in general. Solutions we found is that the lipid management is a project that is being driven by the PCN team. This is because we've got a very good relationship with our practice pharmacist and the practice leads, and they have felt that this can be handed over to the PCN. So this does take a bit of pressure off the practice. We've had a bit of understanding of ours roles. Obviously, as the roles have developed, there is more understanding. So training is becoming more frequent, and that means workload planning has got better and delegation to the PCN staff has happened. Neighbourhood working supported by the system colleagues, obviously Kessel, they can come into the practice, they do really help. Utilisation of digital tools, AccuRx, we use that for our florries, our questionnaires, batch messaging. We use AccuRx quite a lot for lipid management. EMIS searches, Arden searches and Arden's templates, and then obviously the GP Automate, which we self-fund. Top tips would be start early for QOF. Obviously, everyone knows that. Digital solutions, use your digital tools. They are really, really helpful. And then just planning and training of your PCN staff, utilise your technicians, get your pharmacists to train your technicians. And I think that's about it. Yeah, thank you for listening.
That's great. Thanks, Kirsty. Thanks for that overview of what you are doing. We will whiz along onto our next speaker. You did a nice little comment on Arden's. Matthew is going to talk to us about Arden's Manager with a very brief update of how it can help you identify your gaps and address them. So straight over to you, Matthew.
Thanks, Helen. Can you all see my slides?
We can see them, yep.
Perfect. So I'm Matthew, populational pharmacist working across South East London ICB and Guy's and St Thomas's. So let's begin. So I'll whiz over a few things. But Arden's Manager, what is it? It's a population health management tool that is turns data from EMIS into actionable insights. It's integrated directly with EMIS Web. It provides real-time data and multiple dashboards to support you identifying patients in your practice. And if you have your NHS smart card, you'll be able to see directly who the patients are who you can identify for intervention. So here is what it will look like when you log in. The slides will be shared afterwards, so you can also have a look at this. So within Arden's Manager, there's a dedicated QOF 2526 dashboard available for you to easily identify patients that fall within a specific indicator. On the left-hand side, as you can see here, after logging in, you click Contracts and select QOF 2526, and it'll bring you to the landing page. On this landing page, what you have here are the various clinical and public health domain headings related to QOF. There are available searches directly linked to the relevant lipid indicators. So you have the first one, which identifies patients eligible for statin or another lipid-lowering therapy for secondary prevention, linked to the two QOF indicators here, which includes patients with cardiovascular disease or chronic kidney disease. Also have searches which will take you directly to patients who meet the criteria for the diabetes-related QOF indicators for primary and secondary prevention. And then you also have direct searches, which identify patients with severe mental illness who have or have not had lipid profile in the preceding 12 months if on antipsychotics, or in the last 24 months for all other patients within this cohort. So here I've just expanded the cholesterol treatment to target indicator. And up here, what you have in the red circle are the 2 lines indicating for your individual practice how you are currently meeting the minimum or maximum threshold, or if you're not, so you can see how you're doing. Also, there's a filter button here where what I'm showing you at the moment is filtered to show remaining only, but you can also look at those who have achieved or remaining and achieved altogether. So almost like a to-do list for you to be able to manage your patient list. I'm just going to show you another example on ARDAS Manager, which looks at some cardiovascular disease prevention dashboards. And there are 3 pre-built searches, 1 for primary prevention, and there are 2 for secondary prevention. And here is just some dummy data where I've expanded the primary prevention search. And this is looking at a GP practice where patients with a Q risk greater than 10% and less than 84 years of age who may be eligible for statin initiation. In the bottom corner here, there is an export button, which will allow you to export as a CSV file for, say, AccuRx batch messaging, or as a text file for EMIS for you to go directly into those patients' records. In the top right-hand corner here, you can select the patients that you want to review or see, and you can assign them to a suitable member of staff in your practice for review. So say you're planning a clinic, you can select patients and assign them to a suitable member of staff. On the right-hand side here, it looks a bit busy, but this is just the breakdown visual of the key demographics of patients in this fictional practice that have been identified in this search. Every search in the ARDAS Manager can be filtered for targeted interventions, where you could target patients based off of their age, gender, ethnicity, deprivation, comorbidities, or even continuity of care RAG ratings for prioritization. So ARDAS Manager can seem a little bit of a minefield, and there is a lot to its functionality. However, what I would do is I'd recommend giving it a try and starting on a specific group, but perhaps one of those cough indicators or a cohort that you want to easily identify for intervention or to support your clinic. I've put some links here for some further help and support, and some contact details are listed. I think I've done that in 5 minutes, Helen.
That was fantastic, Matthew. Sorry you got a bit truncated at the end there, but we have had some fabulous talks. And I would encourage you to have a look at ARDAS Manager, because a lot of it is fairly intuitive as a sort of Windows-based system. You can work your way around. I'm going to hand over to Rob, who's got probably 30 seconds to sum up. And any Q&As we will deal with after the fact. I've answered the one that we had in the box, in the chat box.
Thanks, Helen. So yeah, those who don't know me, I'm Rob McCarthy. I'm AD for long-term conditions, work with Helen and Astrid in the central team and with many other people as well around CVD. We have gone over time, but this webinar, I think, is about emphasising the huge health outcome benefits that better lipid control can give us, and then to offer some really practical help about how that could be done. And I think we've done that. I think my huge thanks to the excellent presentations. So Lara with a Kessel offer, and then a really fantastic real life example from Kirsty in Greenwich about what she and her PCN colleagues did to improve lipid control, and also Tony and Matthew. Really, really good and informative stuff. In terms of next steps, I think there's something about utilising the resources we already have in the system. So Kessler are an obvious example here, but Tony had a slide that showed some of the other resources we have. Plus, I think Kirsty also showed how relatively easy, or at least not ridiculously hard, it can be for practices and PCNs to create simple but effective improvement processes. From medicine's optimization perspective, I think there are huge opportunities here, and all our speakers highlighted this. I think there are also some really exciting changes in neighbourhood care. So in line with the 10-year plan, happening right now, particularly around integrated neighbourhood teams. In South East London, we've picked multiple long-term conditions in the initial INT priority cohort. All 6 of our SEL boroughs are focused on CVD. There is a real opportunity within your borough to focus on lipids as a key part of the prevention offer for CVD. And I hope that what's happened over the course of the last hour has given you some thoughts and insight about how you might do that. That wasn't 30 seconds, Helen, apologies, but I did it as fast as I could.
We're only 1 minute over. We were a couple of minutes late starting, just letting people in, to be fair. So we have contracted it into an hour. Thank you all for joining. Any issues, obviously we're based at the ICB, do feel free to get in touch with the team. We're happy to support. Kessel are happy to support. Tony's team are happy to support. So yeah, do get in touch if you have questions, queries, concerns, and we will try to help. Thank you all for coming.
Thanks, Helen. Thanks, everyone.